The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The opinions and ideas expressed are those of the hosts and guests and do not necessarily represent the views and opinions of any organizations we may be affiliated with. As always, follow your local protocols.
Hello and welcome back to another episode of Medics, Musings, and Mayhem. I'm Regan and we have Livia back for another episode of EMS Across the Pond. Livia, great to have you back.
Well, as always, it's nothing but a pleasure and a delight to be back.
Now, we both have been on a little hiatus with a bunch of exams and away rotations, but we're ready to go for another round of learning about point-of-care ultrasound in the field.
And today, we're actually going to be talking about the heart. In other words, cardiac ultrasound.
Let's jump right into the case.
A page goes out for a 50-year-old male presenting with chest pain. But because this is, of course, a rural setting, we obviously know it wasn't our patient that made the call, but his wife. She noticed her husband was experiencing some discomfort and mentioning multiple times he was having some chest pain.
When you arrive on the scene, what do you find?
We see the patient sitting on his lazy boy, but he's clearly uncomfortable.
And jumping right into your primary assessment, airway.
When asking the patient for his full name, he responds, but does sound a little out of breath.
Breathing and circulation.
When simultaneously listening to breath sounds and feeling for a pulse, we hear breathing sounds on both sides and have a good radial pulse.
Disability.
The patient is alert and oriented and appears to be moving all his extremities.
Exposure.
The patient is removing his shirt to get the 12 lead on. You do not notice any obvious chest wall deformity or trauma.
Your partner in the meantime was taking some vitals and got a heart rate of 110, a blood pressure of 140/96, respiratory rate of 18, and an SpO2 of 97 on room air. Additionally, that EKG is printing out now, and we can see that computer interpretation up on top says abnormal EKG unconfirmed. Inferior ST abnormality is nonspecific. So quick pause, because most of us who are reading these EKGs are trained to never look at this computer interpretation, figure it out for ourselves. But when you're on a BLS service, you do have to use that computer interpretation because most EMTs are not trained to be able to read those EKGs and report them to the facilities. So in some cases, you do have to look at that computer interpretation. And in this case, kind of unhelpful. It doesn't quite know what's going on. But let's say you do a manual read of this EKG and you also don't know what's going on. You know it's not a normal EKG, but it's not an obvious like ST elevation or depression. But you have this suspicion based on this clinical picture that it is a myocardial infarction. So what do you do in these cases when you have chest pain and the top of your list is an MI? How are we treating these patients? So in the US, it's going to be split between a BLS service and an ALS service. So in a BLS service, most EMTs are going to be able to give the doses of aspirin and nitroglycerin. They can continue to reassess the patient if they need to do up to 3 doses of that nitroglycerin, and some EMTs are even variants to get IV access. When we jump to that ALS service, of course, they can give the aspirin and nitroglycerin. Some can even start nitroglycerin drips. They can absolutely get that access there and can have that interpretation of the EKG as well as continuous monitoring to see if it develops into anything. If it's a clear STEMI, some facilities do have pre-hospital activations, or we're just calling into the hospital we're going to, telling them what we're seeing, telling them our EKG read or the computer interpretation to let them know what they have coming. Livia, over in the European Union, how are these patients going for you guys?
If you guys remember, here in Poland, our paramedics are university graduates and are required to maintain their level of competency through courses. Many, if not most of our new incoming paramedics already have ALS training. So medically, how we approach an MI isn't going to differ much. But we do an ultrasound, if we can, on our rigs. And that's how we're going to differ a little bit.
So before we jump into what they're going to be doing with their ultrasound probe, just a quick step back talking about that pathophysiology of MIs. To keep it extremely simple, we're just going to talk about the differences between a STEMI and an NSTEMI. So STEMI is that ST elevation myocardial infarction. In comparison, the N in the NSTEMI is a non-ST elevation there. So when you have a true STEMI, you're having complete coronary artery occlusion. So any impaired blood flow to that myocardium will start causing death to that tissue if no reperfusion occurs. So if you don't treat that occlusion, that myocardial tissue is going to die. Usually during these STEMIs, it's a full thickness of the myocardium, which is causing that ST elevation that we see on an EKG. Now, in comparison, an NSTEMI is usually a partial coronary artery occlusion. So you're still having decreased blood flow, but not a complete cutoff, which causes like a supply and demand phenomenon within the myocardium. And it usually starts to affect the inner layer of the myocardium first, or the subendocardial layer. And that's why we don't have those ST elevations yet on our EKG. There's usually, if untreated, a development from an NSTEMI to a STEMI as more of that myocardium is affected. It's kind of the quick and dirty of an MI, because today we really want to focus on what happens with a cardiac ultrasound. So Livia, I'm throwing it to you.
As mentioned, we are going to talk about how to do a POCUS echo. In other words, a cardiac ultrasound. This is going to be a lot of information that I'm going to throw at you. Let's just try to break it down as much as we can. Doing an echo, why do we do it? We do it because it allows us to visualize and evaluate how our patient's heart is functioning. We can actually see in real time how our patient's heart is doing. So it's going to allow us to evaluate hemodynamic changes and pathological heart diseases. We are going to talk about doing a POCUS echo. In other words, a cardiac ultrasound. Doing an echo allows us to visualize and evaluate how our patient's heart is functioning in real time. It allows us to evaluate hemodynamic changes and pathological heart diseases. But because this is such a dense and important topic, we are going to have to divide and conquer this over more than one episode. So I'm sure it will come up later. Why should we use point-of-care bedside cardiac ultrasound? It can be used in some of the following indications. There are significant EKG changes or questionable EKG changes with accompanying clinical symptoms. Chest pain, palpitations, dizziness, shortness of breath, hypotension, and believe it or not, cardiac arrest, because we can assess for cardiac standstill. When we do an echo, our goal is to view one organ, the heart, and as many projections as we can externally. Today, we're going to be looking at what I like to consider the meat and potatoes of an echo. Those views are the parasternal long axis view, PLAX for short, the parasternal short axis view, so PSAX, and the four-chamber apical view. What's really important to know beforehand is that since we are looking at one organ in various views, small rotations and position changes of the ultrasound probe can result in very different images on our screens. Before we continue, for those of you who need a reminder of a few basics on ultrasound, take a quick listen to our earlier podcast, since this episode, we're going to be jumping right into the material. Personally, I like to start my echo, as a lot of other people do, by looking at the parasternal long axis view. The best probe to use in this case will be my sector probe, because it's going to do a much better job of fitting in between those ribs to show us the heart. But if your rig has a butterfly or other similar device, just keep in mind that you might have to account for those ribs sometimes showing up in our images. I'm taking my probe and placing it. Where am I placing it? I'm placing it in the fourth intercostal space, which is approximately the nipple line for males or the inframammary fold to the sternum in females. More importantly, I'm being aware of my probe marker and where I'm pointing it, and that's towards the patient's right shoulder. We didn't really cover this a lot in other episodes because it wasn't as critical, but here it is. That probe marker is going to be a little dot or line that corresponds to the marker, aka little dot, on our screens, which should be on the right because it's emergency medicine and we like to keep things simple. What should we be seeing once we correctly place that probe? Furthest away from the probe, in other words, at the very bottom of the screen, we should see the left atrium, which should be on the side of the screen closer to our screen indicator, aka dot, going into the left ventricle via a visibly active mitral valve. And that mitral valve is going to look like a large white structure just opening and closing, kind of like a barn door, but it's a little more flexible. Above the left atrium and leaving the left ventricle, we should see the aortic valve leading into the aorta. And at the very top of the screen nearest the probe will be the right ventricle, which has much thinner walls. Generally, POCUS is the first cardiac ultrasound view obtained because it will give you an immediate assessment of the general condition of the heart, including ejection fraction and overall left and right ventricle sizes. A helpful thing to remember is that the right ventricle, the aorta, and the left atrium, which will sort of look like they're stacked on top of each other in our image, should be about the same size. And if any of them are larger than the other, that is worth noting. That should be an immediate, okay, let's write this down, and let's ask, why is that? After looking at the heart in POCUS, all we have to do to view the heart in the parasternal short axis view is rotate our probe around 90 degrees towards the left shoulder, staying in that fourth intercostal space. When we rotate our probe, we should see the left ventricle closer to the screen indicator and the right ventricle closer to the top of the screen. In other words, we're looking for a donut and a croissant. As we remember from anatomy, that left ventricle is always way more muscular than the right ventricle. So that thick circular structure lower on the screen is that donut shape, while the more crescent thin-walled structure above is our croissant. In this view, spanning the probe, so keeping it in place but tilting it towards either the patient's head or the patient's feet, is going to show different levels of the ventricles. The mitral valve level is when we have our probe perpendicular to the patient, so our original position. As the name suggests, we should be seeing the mitral valve, surrounded by that muscular left ventricle. If anyone's been fishing, this image looks exactly like a fish mouth, just opening and closing. Since one of the objectives of this view is to determine left ventricle wall abnormalities, a very easy trick we can use to determine if any wall abnormalities are present is to just stick our finger in the fish's mouth, aka place that pointer finger directly on the screen over the mitral valve. Why are we doing this? It allows us to determine a little bit easier if any of the wall segments are behaving abnormally. All the wall segments should be contracting together, closing around your finger. That fish is trying to eat your finger. If one part of the wall isn't contracting like the other parts of the wall, that's something to definitely note. To get the other views that we can when we're at that fourth intercostal space, we're going to tilt the probe a little bit towards the patient's head, and that's going to be the aortic valve level. That's going to allow us to visualize the right ventricle, right atrium, left atrium, the aortic valve, tricuspid valve, and the pulmonic valve. But we're not going to talk about this view because it's used to perform more advanced point-of-care ultrasound in a more stable setting. So that's why I'm just mentioning so you know it's there. Let's tilt the probe down towards the patient's feet, and that's just going to show us the mid-papillary level. So it's just going to be those papillary muscles that we see lower down within the left ventricle. I just threw a lot of information at you, but we still have a little bit more to go, so bear with me. After we do that POCUS and that PSAC, we're going to move into the four-chamber view. The apical views are some of the most important views to be able to obtain when doing hemodynamic assessment of the heart. This includes looking at diastolic function, valvular regurgitation, cardiac output, and also wall contractility. And fortunately, it can also be one of the most challenging views to obtain when first starting out. This can be for a multitude of reasons, such as patient anatomy. For example, women with larger breasts or our obese patients. To get this view, we want to slide our transducer down from the parasternal short axis view towards the apex of the heart. Typically in men, this is under the nipple, and in women, under the left breast. The probe marker should be pointing more towards the patient's left side, but not quite at the left shoulder. The image we should see on screen is the left atria and the right atria at the bottom of the screen, then the mitral and the tricuspid valves, and finally the left and right ventricle. The left ventricle is going to have more of a bullet-like shape, while the right ventricle is going to have more of a boat sail shape. If we don't get this image, we can slide our probe more towards the patient's left side or even try tilting that probe upwards towards the head of the patient. Unfortunately, this is one of those views that really requires hands-on practice to understand the little nuances of small movements.
And like we've said before, learning ultrasound via any modality is going to really increase your knowledge, but it is something that you got to get hands on. And on one of my past rotations, we ultrasound so many patients, and it still took me a really long time to get that apical view just right. I felt like I struggled with it on almost every patient, but when you get it, it's just like a complete satisfaction because you can see this whole heart function, and it's a really beautiful picture to pull up. But again, to aid in Livia's explanation, which is phenomenal, but we've added some resources into our website and on Instagram that can show what these images are supposed to look like so that when you're practicing, you kind of have a reference to say, okay, my apical is not quite there. How can I move my hands? And once you have that hands-on practice, that's really the key to getting these images. So moving on to the evidence-based medicine corner, I have two different studies for us today. One is talking about specifically ultrasound within the cases of myocardial ischemia, and the other one is another plug to say that ultrasound is awesome, and I'm just going to keep trying to reiterate that in these episodes. But our first one here is called The Diagnostic Accuracy of Cardiac Ultrasound for Acute Myocardial Ischemia in the Emergency Department, a Systematic Review and Meta-Analysis. So this is kind of top tier research where it's combining all of these other research studies into its results. So this was talking about how to diagnose acute myocardial ischemia in the ED. And interestingly enough, it was talking about like H&Ps, so history and physicals, EKGs, troponins, and then ultrasound. Trying to narrow it down and focus in like our case, we had an EKG and we'll have an ultrasound based on what Livia and her team are going to do in the field. So now EKGs can still have a pretty low sensitivity for myocardial ischemia. They are pretty specific though, but it's not to the point where I would solely trust it based on an EKG, especially in these cases early on, when there's not those clear, definite ST elevations happening on an EKG, but you know that something is going on. So with an EKG, it can have a sensitivity as low as like 29%, sometimes as high as like 45%. The range is pretty wide. But when it comes to putting an ultrasound probe onto these patients, the sensitivity and specificity jump way up. A sensitivity of 79.3% and a specificity of 87.3% for any signs of myocardial ischemia. It's a lot higher than these EKGs. And that's not to say that EKGs aren't helpful. Of course, everything kind of paints the picture together. I will say one limitation with this study, so it's combining a bunch of other study results in it, and there were some studies that varied widely. So there was a lot of heterogeneity in these studies, so we take these results with a grain of salt, of course. Now, the other study that I have, of course, is just plugging for having ultrasound in the pre-hospital field, but it's called Pre-Hospital Ultrasound by Paramedics, Results of a Field Trial. So this was done with two different EMS services. They took paramedics who were willing to go through a 6-hour training, including lectures, written exams, and then a clinical examination, practicing their FAST and their abdominal aortic ultrasounds. Now, we've covered FAST in one of our podcasts, so I'll focus on those results. So there were 6 pre-hospital FAST exams that were read as positive out of the 84 exams that were done. And these were read as positive by both the paramedic and the physician overreader. So our pre-hospital FAST exams in this study had a sensitivity of 93% and a specificity of 99%. When both of these are in the 90s, we just get a little bit more excited. But I think the really cool thing was that it was 100% between medics and physicians. They both read the same thing on there, which again supports that our medics in the field could be putting a probe to these patients and learning really valuable information that can help the team inside of the walls. Another interesting thing about this study as well is that these exams were performed in less than 3 minutes, which is so quick and an easy thing that we can add in these transport times. Of course, we have a lot of things going on with our patients in the field, but if we have just under 3 minutes, we could add some key information for our in-hospital providers. So let's get back to the case. We have this patient that we think is having an MI. We don't have a very clear EKG, but we're suspicious of it. So in the United States, our BLS units will likely give that 325 milligrams of aspirin, and as well as nitroglycerin. For our BLS services, they can give the patient's nitroglycerin and this is an assist with their prescribed medications. And our ALS services can actually give them the ambulance nitroglycerin. Both are usually 0.4 milligrams, and they can be repeated up to 3 doses. Additionally, we're usually putting oxygen on these patients, even if they have an okay SpO2, because our suspicion is ischemia. So we want to cover that a little bit more with some oxygen. Usually a nasal cannula is just fine unless we're having some decrease in our SpO2s. And additionally, we want to get access. If we're able to get an IV in, if we're able to get 2 IVs in, it can be helpful, especially if these patients are going to have an end result of going to a cath lab. And like I said, with our ALS services, they can repeat those EKGs, they can manually read those EKGs and do continuous monitoring to see if there's any other cardiac arrhythmias that happen. In addition, in the field, if you do have a ST elevation, either read by the computer or read by the medic, sometimes those activations can happen for inside the hospital from the medics. If they don't, we still give those in-hospital providers a report of what's going on so they can be best prepared for what's coming in. Throwing it to you, Livia, now, how is that going to go on in the European Union?
I have an ultrasound on the rig with me. While my partner is preparing the meds for a possible MI, I can do a quick echo and check and make sure and see and give myself a little bit more certainty of our primary diagnosis. What I see is a decrease in contractility in the segment of the heart that corresponds to an inferior MI. And right then and there, I have just that much more certainty that considering all the clinical symptoms, what the EKG is showing, what the echo is showing, let's actually come back to that uncertainty we had in reading the EKG from our patient. We don't quite know what it is we have. We think that it's an inferior MI or a type of MI. It's our top differential diagnosis. But while my partner, for example, gets everything ready, the medications, starts the activations for that patient, I can do a quick echo and confirm our suspicions and look directly at that heart. And what do I see when I do? I see a decrease in contractility in the segment of the heart that corresponds to an inferior MI. Now, I don't really need to guess. I don't need to have that uncertainty because I can see it on the screen. I can see it in the EKG, and I can see it based off of my patient's clinical symptoms. And it all comes together in a really nice image of what is happening to our patient. When we see that abnormality in the contractility of the heart, it really stands out. You tend to notice that one of these parts is just not acting like the other. But don't take it from me. Actually, before this episode, Regan and I were talking about her new experiences with cardiac ultrasound. Regan, why don't you describe what it was like seeing your first wall motion abnormality on an ultrasound that you obtained?
So I have just started kind of learning ultrasound. I am nowhere near the level of Livia, but I did recently have a nice experience where I placed the probe on the patient. It took me a second to get the images because I'm still learning. But as soon as that image popped up, it was like a gut reaction of like, that doesn't look quite right. And it might not pop into your head immediately that you're like, oh, it's this wall motion abnormality. You might just look at it and be like, that seems off, or that doesn't seem like it's moving with the rest. And sometimes it takes a second to stare at it to really figure out what's going on. But within seconds of having the image, my gut was just like, wrong. Something's not right there. And maybe Livia has a more elegant way of saying it. She probably does. But for me, just learning, it was pretty easy to see that it was not quite correct.
And that's all you need to know. That's kind of the beauty of an ultrasound, especially with cardiac ultrasound. That heart likes repetition. It likes doing the same thing over and over again. And when it suddenly does something that's not the same, we see it. We see that something is different. With a cardiac ultrasound, there's so much involved in knowing and understanding the underlying anatomy that it seems far more complicated than it actually is. When you're first starting out, what's really important to just recognize and know is that something stands out. Something seems wrong. From there, it's really easy to see the patterns of, okay, this part seems to be corresponding to an inferior MI. This part seems to be corresponding to an anterior MI. Because it involves describing what part of the ultrasound, what part of the wall is corresponding to which segment, to which EKG lead. Instead, we're just going to put onto the website a really great article that shows you how these colorful diagrams can be directly overlaid onto an ultrasound and show us very simply what segments correspond to what kind of MI.
So after we get all of this done in the field, we of course bring our patient in to the closest emergency department, and we're rolling into that ED. We come into the room, and like any wonderful emergency medicine provider, they create a nice space for a pause. And there we get to give our report of all of the hard work that we did to the team in the emergency department. So here we're going to say something along the lines of, Mr. John Doe is a 50-year-old male, history of hypertension. He's presenting with substernal 9 out of 10 chest pain that started 1 hour prior to our call. Our initial vitals were a heart rate of 110, blood pressure of 140 over 96, and he was 97% on room air. Patient was given 325 milligrams of aspirin and 1 dose of nitroglycerin in the ambulance with improvement to his pain. Currently, the chest pain is now a 7 out of 10. Vitals have decreased to a 98 heart rate, 130 over 94 blood pressure, and we did put him on 2 liters, which he's now at 99%. Patient doesn't take any medications, he has no known allergies, his spouse is on the way, and here is our EKGs that we got in the field. And then usually there's just like a stack of EKG papers that we hand off to the team, which are extremely helpful, and I promise the team does go through them. Another thing that we can add, if we did it into the field, would be that ultrasound information. Livia, how would we just share briefly what we found?
We did a cardiac ultrasound that showed decreased contractility in the inferior segment. Doc, I have the images for you when you want them.
Perfect. Livia, it is always an honor to have you and your wide knowledge about ultrasound on the podcast. Especially after our brief time away, it feels really good to be back into the seats here. So thank you for sharing your vast knowledge about ultrasound with our listeners. For our next topic, we are open to any ideas that our listeners want to hear about. Any topics or any questions that you've been having while you're learning ultrasound, or if you want to implement it in there, whatever you guys want to hear, send it to us on Instagram, on our website, via email, so that we can pick at the brilliant mind of Livia and have her back for some more.
As Regan said, we definitely discussed it, and I think it's a great idea. We want to know what you guys want to know more of, and then we can talk about it. And, like a broken record, remember, ultrasound is never a hindrance, but instead a fantastic tool.
So may your mayhem be well controlled, full of teachable moments, but also provide you with the opportunities to provide your patients with the best care possible.